Hi everyone, this is Dr. Sajid, dental surgeon and consultant periodontist. Today I'm going to speak to you about the long-term maintenance programs following active therapy, that is termed as maintenance, is called as supportive periodontal therapy by the American Academy of Periodontology in the year 1986. In 2003, the American Academy of Periodontology positioned the term as periodontal maintenance therapy. Supportive periodontal therapy is a term given to take care and proper maintenance of the patient after completion of the periodontal therapy. One of the causes of the failure of the periodontal therapy is the inadequate follow-up. Hence, the patients as well as the specialists should be made to understand the significance of the supportive periodontal therapy. Now coming to definition. How it is defined? What is it? According to GPT, in the year 2001, procedures performed at selected intervals to assist the periodontal patients in maintaining oral health. According to Jane Linde, it is termed as therapeutics measures to support the patient's own effort to control and to avoid reinfection. What is the rationale of periodontal therapy? According to Von Herg, Jane, 1978, is termed as incomplete subgingival plaque removal. That is, the bacteria which is present in the gingival tissue, mainly in chronic and aggressive periodontitis, and the bacterial transmission between spouses and other family members. Recurrence of the periodontal disease is the microscopic nature of the dentogingival unit healing after the periodontal treatment. According to Phillips R.V. et al. In the year 1980, the subgingival scaling altered the microflora of the periodontal pockets. In a single session of scaling and root planing in patients with chronic periodontitis resulted in significant changes in the subgingival microflora. Alteration included a decrease in the proportion of the motile rods for 1 week, and you will see an elevation in the proportion of coccoid for the 21 days. A marked reduction in the proportion of spirochetes lasted for 7 weeks. So this was termed by Phillips R. et al. In the year 1980. Now coming to any pockets, when you have although pocket debridement suppression, the subgingival microflora associated with periodontitis. Periodontal pathogens may return to the baseline levels within the days of work. The return of the pathogens to pre-treatment levels generally occur approximately 9 to 11 weeks, but can vary dramatically among patients. Goals of supportive periodontal therapy. Now I'm going to speak about that. The 3 main goals according to AAP in the year 1998. To prevent or minimize the recurrence and progression of the periodontal disease in patients who have been previously treated for gingivitis, periodontitis, and for periimplantitis. To prevent or reduce the incidence of tooth loss by monitoring the dentition. To locate and treat other diseases or conditions found in the oral cavity in the timely manner. What are the objectives when it comes to periodontal condition and general condition? Now I'm going to speak to you something about the periodontal condition. In periodontal condition, we see the preservation of bone support, maintenance of stable clinic attachment loss, reinforcement of proper home care, maintenance of healthy and functional and oral environment. When it comes to general, the assessment of the general health status is very important. Encouragement of the patients of oral hygiene efforts, continuation of patient education, and establishment of the future maintenance regime. What are the various types? According to Shalon and Snyder in the year 1981, it's given that preventive maintenance therapy. There, the periodically seen healthy individuals. In trial maintenance therapy, you will see mild to moderate periodontitis. Compromised maintenance therapy, where you will see medically compromised patients, where active therapy is not possible. And finally, post-maintenance therapy, where you will see maintenance of prevention of recurrence disease. According to Carranza now, maintenance of program, supportive periodontal therapy he has stated that examination and evaluation should be given at least 14 minutes. Maintenance and treatment and oral hygiene reinforcement should be done for 36 minutes. And report and cleanup and scheduling should be given for at least for 10 minutes. Now coming to part 1, examination and evaluation. What will you do? First, the patient has to be greeted well. Then you change the medical history. In that you look for oral hygiene status of the patient. You will go for the gingival changes, any changes there. You look for pocket depth and changes. In that you look for any tooth which is mobile. You look for occlusal changes, dental caries, oral pathological examination, and finally restorative prosthetics and implant status has to be checked. Radiographs are very important when you have to look at any condition. So we look for periodontal disease not under good control. You need to take a periapical or a vertical bite radiograph of problem area every 12 to 24 months. And we always request for full mouth series of every 3 to 5 years. History of the periodontal treatment with disease under good control. We usually ask for bite wing examination every 24 to 36 months, full mouth series for 5 years. And now coming to part 2. What is the part 2? Maintenance treatment and the oral hygiene reinforcement. Coming to part 2. We are now going to speak about maintenance treatment and oral hygiene reinforcement. Under that, we have to look into the oral hygiene reinforcement where scaling is done, polishing is done, and whereas other chemical irrigation site, the specific antimicrobial placement. Part 3, report, cleanup and scheduling. We have to write a report card always. It's very important to document something. Then after we document, we have to discuss this report card with the patient. Then filing to clean and disinfect the operatorium. Schedule the next recall visit. Schedule further periodontal treatment, followed by schedule or refer for restorative or prosthetic treatment. Frequency of supportive periodontal therapy. In the year 1993, Ramford et al. For most patients with gingivitis, but no patient at previous attachment loss, supportive periodontal therapy was done twice a year. For patients with previous history of periodontitis, 3 months interval less than 6 months, followed by various clinical trials such as 4 times a year. I just want to briefly describe you about the classification, the post-treatment patients according to Marin. First year, he has divided, the patients will have a routine therapy and uneventful healing. That takes about 3 months. The first year, the patients have very difficult. They have complicated processes and involvement of poor crown root ratio or questionable patient. That will take to 1 to 2 months. Class A condition where you see excellent results, well maintained for 1 or more years. That will be always a recall interval for 6 months to 1 year. Class B, we are going to see about generally good results in this condition. They are maintained reasonably well for 1 year or more. But patient displays some of the factors like they have inconsistent or poor oral hygiene, heavy calculus formation, some relating pockets will see occlusal problems, and various ongoing orthodontic therapy, some of the teeth with less than 50% of the alveolar bone. So here in this condition, 3 to 4 months, we have to do a recall based on the number and the severity of the negative factors. Coming to the last one, the class C. Here, many teeth with less than 50% of the alveolar bone support is taken care. Here in this condition, a recall is very important for 1 to 3 months. It decides on the recall interval based on the number and severity of the negative factors of the patients. Now I'm going to speak to you about periodontal risk assessment for patients in supportive periodontal therapy. The patient's risk assessment for recurrence of periodontitis may be evaluated on the basis of the number of clinical conditions where no single parameter displays a more prominent role. The entire spectrum of the risk factors and risk indications to be evaluated simultaneously. So we will begin with The purpose, what is the purpose? There's something called a functional diagram has been constructed with the aspect of where you look for percentage of bleeding on probing, you look for prevalence of residual pockets which are greater than 4 millimeters, followed by loss of teeth for a total of 28 teeth. You will also look for something of periodontal support in relation to the patient age also. Age is also very important. We look for where the systemic and the genetic condition of the patient, followed finally by the environmental factors such as cigarette smoking. This was all recommended by Lang and Tony in the year 2003. This has been put in a diagrammatic view where you show a low PR patient has all parameters within the low risk category, at the most one parameter in the moderate. This is the first part. Finally, you will follow with patients with PR have the lowest at least 2 parameters in the moderate category, but at one most parameter in the higher risk category. And lastly, you will have patient has at least 2 parameters in the higher risk category. What is the effectiveness of supportive periodontal therapy in case of gingivitis? This was told by Linde in the year 1974 that he demonstrated that the gingivitis could be prevented by regular professional cleaning in children with the age 7 to 14 years. Batson et al. In the year 1990 followed it, that stating that routine mechanical subgingival debridement of shallow bleeding sites had to be taken in case of attachment loss. In 1981, Linde reduced the caries and bleeding on probing. Finally, followed by the gingival condition improved by 60% and tooth loss was reduced by 50% in the year 1961, stated by Laudel et al. And in 1971, the mean loss of probing attachment was only 0.8 millimeters per surface as opposed to 0.3 millimeters in the control group. It was stated by Somi et al. In 1971. Now I'm going to put a light on something on periodontitis. In periodontitis by Niem et al. In the year 1997, reported on 25 patients for 2 years where he said no supportive periodontal therapy was done. Regular supportive periodontal therapy was done 3 to 4 times a year, which allows to disease monitoring. And sometimes you can even early detect any problem and treatment will be given. And in the year 1992, Delhen, he professionally delivered supragingival tooth cleaning in combination with self-perforate plaque control for 2-year period, and which was very effective, and the quantity and the composition of the subgingival microbiota. Hellstrom et al. In 1996, the same protocol he followed, but he had a significant effect on the subgingival microbiota of moderate to deep periodontal pockets seen clinically. Linde in the year 1984 claimed that 75 patients with extremely advanced periodontitis recurrent infection occurred in only various few sites during a 14-year period of effective supportive periodontal therapy. So here you see that the recurrent periodontitis was noted at completely unpredictable time intervals in about 25% of the patients in regarding to 15 of the 61 patients. Supportive periodontal therapy can be used by in the form of antimicrobial or by antibiotics. Antimicrobials have been used to compensate for inadequate mechanical oral hygiene. Antimicrobials can be administered using different delivery systems, some like dentifrice, solutions for oral rinse or flushing of the periodontal pockets, and other local delivery systems. Now something called triclosan. It's a very important one. It's containing a dentifrice. This reduced the subgingival microbiota both quantitatively and qualitatively over a 3-year period without concomitant use of subgingival mechanical treatment. And very important point is use of chlorhexidine rinse over 3 years at various intervals may always prevent tooth loss. And chlorhexidine is always important in controlled release delivery system. Something called a periochip in patients result pockets after initial cause related to therapy appeared to be effective in a 6 months study. Recurrence of periodontal disease. How does it occur? Very important. It is inadequate plaque control. Here you will have inadequate restorations, you'll have presence of some systemic disease, failure of the patient to return for periodontal checkups. So how does it cause? Failing causes can be recognized by the what? How can you recognize them? Recurring inflammation revealed by gingival changes and bleeding on probing of the sulcus of the probing. Increased depth of the sulci, that leads to what? Recurrence of pocket formation. Then there is gradual increase in bone loss as determined by the radiographs. And there's a gradual increase in tooth mobility as asserted by clinical examination. Patients with periodontitis associated with tooth loss are significantly increased risk of developing periimplantitis. The overall periodontal condition in partially edentulous patients can influence the clinical condition of around the implants. The microflora of the implant is partially edentulous patients differ from them in the edentulous patients. The implant microflora is similar to the tooth microflora in the partially edentulous patients. So what you do in the general maintenance of patients with implants, patients with natural teeth, how you differ? You have some kind of special instrumentation which used. The metal hand instrument and the ultrasonic tips should be avoided because they can alter the titanium surface of the implant. Only plastic instruments or specially designed gold-plated curettes should be used for calculus removal. There's something called rubber cup with pumice and tin oxide or special implant polishing paste should be used on abutment surfaces with light and intermittent pressure. Acid fluoride prophylactic agents should always be avoided and non-abrasive profess paste are used. I'm going to speak something about CIST. What is CIST? It is a cumulative interceptive supportive therapy. What happens? Depending on the clinical and eventually the radiographic, we take care with the help of the radiographics also, the protocol for preventing and therapeutic measures designed for intercept the development of peri-implant lesions. The system of supportive therapy is cumulative in nature and it includes 4 steps. First one, you will see the absence of plaque when bleeding on probing is negative in periodontal probing depth which is less than 3 millimeters. You will have no treatment to be done there. But in some cases there is presence of plaque and there is bleeding on probing. So you will have a mechanical debridement and polishing should be done there. With the probing depth of 4 to 5 millimeters, when you look so that you have some antiseptic cleaning is done. You use of radiographs with periodontal ligament with probing depth is greater than 5 millimeters, then the bone loss is less than 2 millimeters, you'll have a systemic or local antibiotic therapy followed by bleeding and probing with bone loss greater than 2 millimeters. You have to do a resective or a regenerative surgery. What is the compliance with the maintenance therapy? How will you compliance with that? Compliance has been defined as what? The extent to which a person's behavior coincides with the medical or health advice. The first study on the degree of compliance with supportive periodontal therapy was published in the year 1984 by Wilson, where he had 1,000 patients followed up for 8 years, and only 16% complied with the suggestion of supportive periodontal therapy intervals. Of that, 34% never came back for maintenance, and 49% rest compared with erratically. With that, I'm coming to the end of my topic, and now I'm going to just brush you up on what I've spoken to you so far about supportive periodontal therapy. And this is what you should understand by now. It is a supportive periodontal therapy can keep periodontium and peri-implant tissue healing after active therapy. Patients who comply to suggested supportive periodontal therapy keep their teeth longer. And finally, average supportive periodontal therapy visits, very important, should last for 1 hour and should be scheduled every 3 months depending on the patients. I hope you understood the topic which I have spoken today on supportive periodontal therapy. I will come back to you with the next topic very soon. Thank you.